This diagram shows the systemic circulation of blood around the body and how this relates to the kidney. And we can use this diagram to show how there are three main etiologies for acute kidney injuries. There can be a problem with the perfusion of blood before it gets to the kidney, which is known as a pre-renal acute kidney injury. There can be a problem at the level of the kidney itself, which is known as an intra-renal acute kidney injury. And there can be a problem with obstruction of the urine that is coming out from the kidney, which is known as a post-renal acute kidney injury. In a pre-renal acute kidney injury, the main problem is hypoperfusion of the kidney or reduced blood supply towards the kidney. This can be because there is just generally less blood in the systemic circulation, which can come from things like gastrointestinal losses or bleeding, which both leads to depletion of intravascular volume and therefore less blood getting to the kidneys. Apart from volume depletion from gastrointestinal losses, you can also lose volume through the skin from severe burns and even sweat, markedly reduce oral fluid intake, or excessive urine output, whether that be from things like polyuria, from glucosuria, or diuretic use, can all lead to volume depletion, hypotension, and potentially a pre-renal acute kidney injury. In the setting of chronic liver disease and portal hypertension, there is vasodilation and accumulation of blood in the splanchnic vasculature, which therefore leads to less blood in the rest of the systemic circulation, which can also lead to hypoperfusion of the kidneys. This is known as hepatorenal syndrome, which is one of the severe manifestations of decompensated liver disease. In the setting of chronic heart failure, particularly heart failure with reduced ejection fraction, there can be reduced cardiac output because of compromised cardiac function, and therefore there would be less perfusion of blood towards the kidney. This process is known as cardiorenal syndrome, which can be a manifestation of severe decompensated heart failure. I described this heart-liver-kidney axis in more detail in another video, which I'll put a link to here. Another mechanism which can occur in severe sepsis is when there is systemic vasodilation, which leads to hypotension and therefore reduced perfusion to the kidneys. It is therefore not uncommon to see patients who present with severe sepsis also having a concurrent AKI. In all of these mechanisms, the end result is hypotension and hypoperfusion to the kidney. But because all of these pathologies occur in the blood supply prior to the kidney itself, these pathologies are all classified under the umbrella term of a pre-renal AKI. The cause of a pre-renal AKI is usually apparent from the clinical history or the clinical examination, with hypotension as a key feature. But sometimes the diagnosis is not completely clear, and there are a few tools we can use to help us determine the type of acute kidney injury. A useful tool is to look at the urea-creatinine ratio, which can help distinguish a pre-renal versus an intra-renal acute kidney injury. If we go back to our nephron diagram, we know that the blood through the glomerulus is filtered through the nephron, where sodium and ultimately water is reabsorbed through the nephron to produce urine. These processes rely on various channels and transporters, which I go through in more detail in another video, which I'll attach a link to here. Urea is a nitrogenous waste product of protein metabolism and is freely filtered with about 50% reabsorption as it passes through the nephron, most of it occurring proximally. Urea reabsorption is a passive process and therefore relies on the flow rate at which the fluid is passing through the nephron. In the case of a pre-renal AKI and renal hypoperfusion, the fluid and urea that is filtered through the nephron will be passing through at a slower rate, which therefore means that there is an increased amount of contact time between the fluid in the nephrons and the tubular cells, which means that there will be a greater degree of passive urea reabsorption back into the blood. And so, because of this, you would expect that in the case of a pre-renal AKI, the serum urea would be higher than normal. In contrast, creatinine is filtered through the nephron and is not reabsorbed, with the serum creatinine level being reflective of the overall glomerular filtration rate. And because there is no reabsorption of creatinine through the nephron, the flow rate through the nephron, depending on the degree of hypoperfusion, would not affect the serum creatinine level. And so in a pre-renal AKI, we would expect the urea-creatinine ratio to be increased, because relative to creatinine, the rate of reabsorption of urea and hence serum urea is increased. In contrast, in the case of an intra-renal acute kidney injury that involves tubular damage, there will be a reduced capacity to passively reabsorb urea through the nephron, and therefore the serum urea will be relatively lower than expected. In this situation, the properties of urea become more like the properties of creatinine, where it is being filtered and not a lot of it is being reabsorbed, and therefore the urea-creatinine ratio will be decreased in the setting of an intra-renal AKI affecting the tubules. The cutoffs that are generally used to define a high or low urea-creatinine ratio are more than 100 for a high urea-creatinine ratio and less than 40 for a low urea-creatinine ratio, where a normal ratio would be between 40 and 100. Because the units of urea is in millimoles per liter and the units of creatinine is in micromoles per liter, we can quickly look at a set of blood tests to determine if the urea-creatinine ratio is greater than 100 by seeing if the urea is more than 1/10 of the creatinine number that is reported. So for example, if a patient has a creatinine of 80 micromoles per liter, we would expect a urea of less than 8 millimoles per liter if the ratio is less than 100. If this patient has an AKI and the creatinine goes up to 140 and the urea goes up to more than 14, this would be suggestive of a pre-renal AKI. In the case of an intra-renal AKI, you may see a very high creatinine, say 200, but with a normal urea of say 5. In this case, the urea-creatinine ratio is only 25, which is quite low, and therefore would be suggestive of an intra-renal AKI affecting the tubules, such as an acute tubular interstitial nephritis. You can also formally calculate the urea-creatinine ratio by dividing the urea, reported in millimoles per liter, by the creatinine, reported in micromoles per liter, but dividing this number by 1,000 to convert it to millimoles per liter to make it the same units as urea. So to summarize, the urea-creatinine ratio can be a useful tool to help you distinguish between a pre-renal and intra-renal AKI. And so it is good practice to always look at the urea and creatinine levels together when interpreting renal function. When patients have a very prolonged or severe renal hypoperfusion or pre-renal AKI, they can develop a ATN or acute tubular necrosis, which is technically an intra-renal AKI. Apart from using the urea-creatinine ratio, there's another tool you can use to help distinguish a pre-renal AKI from an intra-renal ATN, and that tool is the FENA or fractional excretion of sodium. This is essentially a comparison of the sodium and creatinine levels in the urine and in the serum to calculate the fractional excretion, with the formula being the urine sodium times the serum creatinine divided by the serum sodium times the urine creatinine times 100%. In a state of hypoperfusion with a pre-renal AKI, the kidneys are trying to retain sodium and fluid, and so the urine sodium would be expected to be very low because most of the sodium is being reabsorbed. Therefore, the fractional excretion of sodium would also be very low in a pre-renal AKI, generally less than 1% as the cutoff. In contrast, in ATN or acute tubular necrosis, as its name implies, the damaged or necrosed tubular cells are not able to reabsorb sodium, and so there will be more sodium excreted in the final urine. Therefore, the fractional excretion of sodium would be relatively high in an ATN, generally more than 2% as a cutoff. The caveat to this would be that you would get an artificially increased fractional excretion of sodium when the patient is on a diuretic that blocks sodium reabsorption, such as a loop diuretic. So if you had a patient who was on a diuretic and who you were trying to distinguish whether they had a pre-renal AKI or an intra-renal ATN, instead of doing a FENA, you can do a fractional excretion of urea, which uses the same formula as the fractional excretion of sodium, except you replace the sodium with the urea. Because of the same principles as discussed for the FENA, the fractional excretion of urea will be reduced in a pre-renal AKI, generally less than about 20 to 30%, whereas the fractional excretion of urea will be increased in a intra-renal ATN, generally more than about 40%. Ultimately, the treatment for a pre-renal AKI would be to treat the underlying cause. On top of that, it may be useful to try and rehydrate the patient with intravenous fluid to improve the hypotension and renal hypoperfusion. Generally, for pre-renal AKI supportive treatment, you only need to give about 1 to 3 liters of intravenous fluids per day, although obviously the most appropriate amount of fluids will depend on the patient's situation, and you'd have to give the fluids judiciously if the patient had underlying heart, liver, or even severe kidney disease, to avoid causing fluid overload. Patients with pre-renal AKI generally improve quite quickly with intravenous fluid therapy, within the time frame of about 1 to 3 days, as long as the underlying cause has also been treated or resolved. In contrast, an ATN does not recover that quickly and generally does not benefit from moderate to high volume intravenous fluid, and so practically, the significance of trying to distinguish a pre-renal AKI from an intra-renal ATN is that it will help guide the amount of fluid that you're going to give the patient. In ATN, you just want to maintain euvolemia, whether it be with maintenance intravenous fluids or oral fluids. Whereas in a pre-renal AKI, you want to give relatively more fluids because in some way you're trying to replace a fluid deficit. But either way, you still want to focus on trying to identify and treat the underlying cause. So now that we've discussed the pre-renal AKI, we can go on to discuss the intra-renal AKI.